Good evening, Endo Summit Live, and welcome to session 2 for the 2025 season. We are joined by not only our co-founder, Dr. Andrea Vidali, but we are also joined by Sadiqa Bebahani from California. This is amazing, and coming along soon will be Dr. Ram Cabrera as well. For those of us joining on Zoom, if you have questions, please place them in the chat. I have a whole list of questions coming off of Instagram. Sadiqa, do you want to go ahead and introduce yourself and where you're from?
Yes, thank you for having me here. I'm excited to be here. So thank you for the invitation. My name is Sadiqa Bebahani. I'm a double board certified OBGYN and fertility specialist. I did a double fellowship in fertility and minimally invasive surgery, and endometriosis and fertility is kind of my favorite topic to discuss and my favorite type of patients to treat, just because there are very few physicians across the country who specialize in both fertility and endometriosis, and there's a huge need to help serve our fertility patients and provide them with better endometriosis diagnosis and treatment. So I'm excited to be here today.
We are so happy to have you. Also joining us is the Endometriosis Summit co-founder. Andrea, do you want to introduce yourself?
Yeah, good evening, everybody. Andrea Vidali. Interestingly enough, I have a very similar background to Sadiq's. I think we're probably, I don't know, there may be others that I know of, but in terms of people doing for endometriosis fertility, I know of Dr. Antonio Gargiulo in Boston, and I think I think you work with Antonio, or were you there
I
at the
know
Brigham?
him. Yes, I've
Yeah.
not worked with him, but I know him
Okay, I thought you were at
personally.
the Brigham. Yeah. And Dr. Gargiulo, obviously same background. So, lovely to be here tonight with you and with Dr. Sorrell.
Yes, also shout out, I think Zarak Khan is the other one who's had the
Yes.
RV, and the MIGs who will be joining us later in the season. And Sadiqa, so you know, he already designed a panel for Endo Summit 2026 that he named you to. So now you're stuck with us. So this year we are sharing presentations. Do you want to go ahead and share your screen?
Absolutely. So always takes a couple of clicks for me to figure out. So please bear with me. And I think if I share and then maybe I can put it on PowerPoint mode. So the slideshow.
I did.
Okay, perfect. Can everybody see my
Got it.
screen?
Yes, we
Perfect.
see it.
Great. So I just have some slides because I think that it's helpful to visually see what we're talking about when we discuss endometriosis. It can be a very difficult concept sometimes to understand, and there's a lot of common misconception about the disease. So I have a lot of surgical slides, a lot of real-time pictures. So if anyone feels uncomfortable looking at surgery pictures, I would recommend just listening in for now. I will go over the surgery pictures first, and then we have slides that have text in them. So I can definitely remind you when the next slide is coming up if it has a graphic image on it or not. So I just forgot to mention where I practice. I'm affiliated with the University of California in Riverside. So I'm an associate professor at UC Riverside, and I currently practice at the Center for Endometriosis and Fertility, which is located in Orange County in California. So coming up are graphic pictures that I've personally taken just to help show better what endometriosis looks like. So this is a text slide. So endometriosis, as you are all aware, affects about 10% of reproductive aged women. That is if we look at any general population. But not everybody with endometriosis has infertility. So about 70% of women with endometriosis can get pregnant naturally, but 30% of women with endometriosis can have difficulties getting pregnant. Now, if we look at another statistic, if we were to examine only women who have infertility that walk through our doors, so women who come to see a fertility doctor for infertility, half those patients will have endometriosis. And this is why it is very important for fertility doctors to have a good understanding of endometriosis, because it is more common than we think. And Sally called this the silent endometriosis webinar because a lot of those patients don't know they have endometriosis. They have infertility. They go to see the fertility doctor, and it is our responsibility to appropriately diagnose them and treat them, because otherwise they get fallen under the unexplained fertility category, where we don't know why they haven't gotten pregnant despite normal testing. If we were to dig further, ask the right questions, run the right tests, we will probably be better at achieving the diagnosis of endometriosis in those fertility patients, and then it will no longer be an unexplained infertility. They will have a diagnosis that we can work on and treat to help them get pregnant. So graphic slide next. This is what a normal ovary looks like, and the reason why I put this slide up is because I wanted to show how endometriosis can be very subtle and can be missed on imaging. So if you go see your fertility doctor and they do an ultrasound and they say your ultrasound came back normal, this does not mean you don't have endometriosis. And here's why. If you look right here, can you see my cursor? This is the uterus right here. This is one ovary, that's another ovary, and this blue-black spot, I'm looking at the top picture here, this blue-black spot is an endometriotic implant on the ovary. This will not show up on ultrasound. If we look at the picture underneath it, those are the small blue deposits on the ovary here. Those, again, may not show up on ultrasound. But if we compare it to the picture right here, this big blue ovary, this big blue cyst, this will likely appear on ultrasound, but it doesn't mean that those two patients did not have endometriosis if their ultrasound comes back normal. Another common location of endometriosis that we see is on the uterosacral ligament. So this is a picture here of all those blue-black deposits that can cause inflammation in the pelvis that will affect the chances of pregnancy. So endometriosis does not have to be on the ovary to affect the chances of pregnancy. It can be on the bladder. This is a picture of the bladder endometriosis. You see this is the uterus and the blue-black spots here on the bladder. It could be in the cul-de-sac, which is actually one of the most common locations for endometriosis. This is between the bowel, this is the rectum, and the uterus. And many of those patients have a lot of other signs and symptoms of endometriosis that unless we ask about, we may not know about. So asking them about bowel function, bladder function is important. Sometimes my patients say, well, doctor, I'm here to ask you about pregnancy. Why are you asking me all those questions about my bowel movements and my bladder pain? Well, it's because it's my job to help connect all those different pieces of the puzzle and help understand what's going on with the body and why patients are unable to successfully conceive. So those implants anywhere, regardless of where they're located and regardless of their size, may be affecting fertility. And we'll go over some studies and data to support that. So how do we do the surgery? It can be done laparoscopically, can be done robotically. This is just a picture of the robot, and it's all done through small incisions, so small laparoscopic incisions. Why did I put that up? Again, because I have sometimes patients who are very hesitant and reluctant to go through surgery to diagnose and treat endometriosis. And what I always compare it to is the gallbladder or the appendix. When the doctor tells you have gallstones and you need to have your gallbladder removed, a lot of patients will say, okay, if that's my treatment, I'll go through with it. So why don't we treat endometriosis the same way? If we suspect endometriosis and we say surgery is the only way to diagnose and treat it, then we should be able to refer our patients to endometriosis surgeons, specialists in the field who can do the surgery minimally invasively with excellent outcomes. And just like with an appendectomy or a cholecystectomy, where we don't really question the need for it, that's how it should be with endometriosis. It's minimally invasive surgery, small incisions, patients go home the same day, they do excellent, just like they would with any other organ removal. And so this is not just for us as physicians or as patients, it's also for healthcare physicians, insurance providers, for everybody to recognize that endometriosis is a disease that has a standard of care when it comes to treatment. And that has to be excision surgery. And if done with the right physicians, with the right team, outcomes are excellent and the risk of complications extremely low. Now, why am I talking about all of this? Because those are just more pictures to show where endometriosis can be located. So diaphragm, and again, why did I put it the diaphragm? Some women say, well, I'm trying to get pregnant. Let's just focus on my uterus and my ovaries. Interestingly, studies have shown that endometriotic implants of distant organs, including the diaphragm, will affect chances of pregnancy. And how does that happen? It's because those implants are very inflammatory. Endometriosis is a pro-inflammatory disease. For women who've gone through it, they know they're always tired, they're always feeling unwell, they don't feel like themselves. And it's because that inflammation is just sucking up and taking up all the energy. And so when it comes to fertility, that inflammation can negatively impact the chances of pregnancy, regardless of where those implants are located. We see here bowel endometriosis that can cause fertility issues as well. Small bowel, large bowel. This is just a bowel resection showing endometriosis on the specimen. It can be on the liver. This is a very unusual location, but this liver was removed and the pathology showed endometriosis on that liver. Vagina endometriosis is also common. Bladder, I showed some pictures. It could be bad, such as this one. And now we will talk about text slides. So for those of you who did not want to look at the graphic images from surgery, we are now talking about just text slides on endometriosis and fertility and the association between the two. So why does endometriosis cause infertility? It can be because of the endo itself, or it can be because of the association with adenomyosis. And that's something that I often have to explain to my endometriosis patients is adenomyosis can co-occur with endometriosis, but it doesn't necessarily mean that the endometriosis is outside the uterus. With adenomyosis, it could be within the wall of the uterus. So endometriosis is when the lining of the uterus travels outside the uterus, but when it makes its way into the muscle layer of the uterus, that's when it's called adenomyosis. So if you look at all those brown implants, those are cells that normally would live in the lining of the uterus, or cells that are similar to the cells that live in the lining of the uterus that are present in the muscle layer of the uterus. So that's adenomyosis. Adenomyosis can negatively impact pregnancy chances. It can affect embryos that are trying to stick, because look at how this inflammation is so close to the lining of the uterus. So women who have adenomyosis, when they undergo IVF, they may be at decreased chances of pregnancy or successful implantation. We have to make the appropriate diagnosis, and we have to recommend the appropriate treatment to improve the chances of pregnancy with adenomyosis. So that's one thing you want to talk to your fertility doctor about when you suspect endometriosis is, do I have adenomyosis? And if we suspect we do, what are we going to do about the adenomyosis to help increase the chances of pregnancy? But the endometriosis itself can affect various organs. We showed pictures of the endometriosis being on the ovary itself. So ovarian endometriosis can impact the egg quality. It can impact the outcomes from IVF. It can affect fertilization rates with IVF. And it can affect just in general, the egg's ability to become a good quality embryo. Endometriosis can wrap itself around the fallopian tubes and can cause scarring around the fallopian tubes. So if the tubes are blocked because of scarring from endometriosis, then that will hinder fertility potential, because the egg and the sperm cannot meet through the fallopian tube. Peritoneal disease, so those pictures of the implants that I showed that are scattered around the pelvis, those peritoneal implants are inflammatory, and they can affect not just the egg quality, but also the ability of the egg and the sperm to fertilize, and then the ability of that embryo to implant in the uterus. So a pro-inflammatory state with peritoneal disease will still reduce the chances of pregnancy. And finally, deep infiltrative endometriosis of other organs doesn't necessarily have to be adenomyosis of the uterus or ovarian endo. Anywhere we find DIE, deep infiltrative endometriosis, bowel, bladder, diaphragm, all of that can reduce pregnancy potential. Ovarian endometrioma specifically can pose a difficult scenario sometimes, because the presence of endometrioma, especially when they're large and they're bilateral, can decrease ovarian reserve. This study mentioned specifically ovarian endometriomas more than 7, but the guidelines, the ASRM-ESHRE guidelines talk about endometriomas more than 4 centimeters affecting endometriomas affecting ovarian reserve. But any size endometrioma, even if it's 1 centimeter, even the small endometriomas can affect the quality of the surrounding eggs. But the problem is, when we remove those endometriomas, we can decrease ovarian reserve. And that's the dilemma that a lot of REIs are faced with. And that's why a lot of IVF doctors are very hesitant in recommending endometriosis surgery, because they're worried that the egg count is going to drop. However, as endometriosis experts, and I'm sure Dr. Vidali agrees, if we perform the right surgical technique, if we perform the right dissection, if we take the right precautions, then there's a very good chance the endometrioma removal will only slightly affect the egg count. So the ovarian reserve or egg count may decrease, but if we do the surgery appropriately and we do it with all the measures that we can undertake to decrease damage to the ovary, then the egg count may not drop significantly. So that is only talking about count, the egg count and ovarian reserve. The egg quality is another situation or question to discuss. So having endometriomas on the ovary will negatively affect egg quality. When we remove that endometrioma, even though we may end up with less eggs on the ovary, the quality of the eggs should be better. So I often review cycles of my patients who've gone through IVF. They've had 20 eggs retrieved. They've made only 2 or 3 blastocysts, and none of them have come back normal. So I tell my patients, what's the point of getting 20 eggs if we only had 2 to 3 blasts and they all came back genetically abnormal? I would rather get 5, 6, 7, 10 eggs, but have an increased ratio from egg to blastocyst. I want to see, my end goal is normal blastocyst development. It is not how many eggs we retrieved or how many embryos we made. It is how many normal embryos we have to transfer into the uterus to get a pregnancy that matters. And so that's why the endometrioma, yes, its presence may decrease egg count, its removal may decrease egg count, but there's another side to the story, is how are those eggs doing? Which eggs are better, the eggs with the endometrioma in place or the eggs once the endometrioma has been removed? So the surgery for endometriosis, like I mentioned, has to focus on specific parameters in order to optimize success and decrease damage to the ovaries. The dissection technique matters, how we stop bleeding. We don't want to be burning the tissue. We don't want to be killing all those eggs on the ovaries. We want to be very cognizant of how we stop bleeding, where we are safely removing the disease, but also not negatively impacting the remaining eggs. So trying to reduce damage to the remaining eggs as much as possible. And then our approach to ovarian endometrioma is how we strip that cyst off the ovary, how much energy we use, how much bleeding we create, all needs to be very fine, gentle technique on the ovaries. And I always tell my mixed colleagues, so my colleagues who are surgeons, who are not fertility doctors, is you want to look good in front of your fertility doctor colleague. So when you send your patients to the fertility doctor to have IVF, you want that doctor to say, your surgeon did a good job. I can still get good eggs from your ovaries. And those are the small techniques that can make or break your dissection. The patient may not feel any different. Her cyst is gone either way. But you want to remove it in a way where you benefit your patient, the cyst is gone, and you help your fertility doctor be able to stimulate the ovary and get good eggs from that ovary. And so why do I keep talking about surgery and improving outcomes? Because studies have shown that in women who have been unsuccessful at getting pregnant with IVF, if we were to go in and remove their endometriosis, their chances of pregnancy significantly improve. And not just with IVF. The biggest take-home message here is that spontaneous pregnancy chances increase. So women who are infertile, they've done IVF, they are unsuccessful at getting pregnant with IVF, we do their surgery, we remove their endometriosis, and all of a sudden, they can get pregnant naturally. They may not even need IVF. And I think that's the important take-home message, is if we remove endometriosis in unexplained infertility patients, we can reverse their infertility and help them get pregnant naturally. More data to show the same. So this is a meta-analysis, which is the highest level of data that we can gather in science. And this meta-analysis showed that in post-op endometriosis patients, pregnancy chances were approximately almost half, almost 50%, so 44.6. And a large percentage of those pregnancies were conceived naturally without IVF. Again, more data, another meta-analysis to show the same results. So if we look at the data here, we see improvement in pregnancy chances in patients who've had their endometriosis excised, and even in patients who did not have complete removal. So in patients who've had their endo excised but were unable to have a bowel resection, for example, or were unable to remove every single spot of endo, even removing the bulk of endo can significantly improve fertility. I'm not saying that's how the surgery should be done, but I'm just saying this is how impactful surgery is, that even if you were not able to remove every single spot of endo, but remove the majority of it, this study showed that even incomplete excision of endometriosis still improved pregnancy chances. And obviously, we have to decide which patients are the ones that need to go through fertility treatment. I'm actually going to stop sharing my slide here so we can give ourselves time for a discussion. So even patients who need to go through IVF, if we do their endometriosis excision surgery first and then do IVF, our egg quality and our outcomes from IVF are usually a lot better than if we have to do the IVF while the endometriomas are still there, creating that toxic environment on the egg.
This
Sally,
was absolutely brilliant. I blown away. That was one of the best presentations we've ever had here on Endo Summit Live. So we welcome you to facultyship, I think, with a bang. It was fantastic. You should see all over how many questions are going on. It's just amazing, amazing, amazing.
Glad you like it. Yep, I'm here to answer questions. That's why I wanted to stop talking, because I have a lot to share, but I don't want to overwhelm the audience. I want to give them a chance to ask questions.
Excellent. Dr. Vidali, I'm sorry, Andrea, any commentary?
No, I thought it was a beautiful presentation, very didactic, and it focuses on the right points. One of the problems that I think and you were obviously pointing to the literature, but one of the dilemmas that we have, and you will probably agree with me, is that there's very little amount of studies available, really. And in fact, I'd like to point out that one of the papers you presented were, probably the best people in literature are Dr. Carmona and Dr. Mauricio Brau, who are who are going to be in. Dr. Brau will be at the summit this year, so I just wanted to make sure that we mention their names because they're the ones who produces the largest amount of literature in this area, fertility and endometriosis. But still, there's not enough.
We
I
also saw
completely
your
agree with you.
phenomenal analysis as well. I did see your authorship on there. It was wonderful. So let's start with our first question. I thought it was very interesting. And by the way, Dr. Ram is here. Everybody wave. And Dr. Vidali, and I'm sorry. So this year, I explained it beforehand. We had a sociologist go through all of our stuff. And they said, I have to stop using all of the MD's last names. If we're all going to call me Sally, we all have to be on even footing. But I keep forgetting to do it because I'm so used to it. So and I'm never going to answer to Dr. Sorrell, so we're going to have to go with the first name. So Sadika, how might someone who is diagnosed with endometriosis know if they're going to have a fertility problem or not? Or do they just try and see?
That's a great question. So it depends on how the patient is presenting. You said, how will a patient with endometriosis know? So I'm assuming they've already received a diagnosis of endometriosis. As we know, endometriosis is only diagnosed surgically. So I see tons of patients who are young, they're not ready to have children yet, but they have pelvic pain, they have endometriosis. We go in, we do their surgery, we remove all their endo. I tell them, you're done. Go and live your life. Try and get pregnant naturally when you're ready to have children. And only if you are unable to conceive after the appropriate amount of time, which is usually between 6 to 12 months, depending on the couple's age, then come back and see me and we'll figure out why. Some of my patients proactively want testing beforehand, like a semen analysis, a tube test, things that are unrelated to endometriosis. We will do that. But for patients who have their endometriosis treated and removed, they should be able to get pregnant naturally with no issues. It's for the patients that have endo that hasn't been treated that pose a challenge. So in women who have endometriosis, let's say they have mild pain, we suspect they have endo, but they really don't want to go through surgery. If they've been trying to get pregnant for 6 to 12 months and are unsuccessful, then they shouldn't keep delaying their pregnancies. We need to do a further analysis into what's going on. We may need to do what people call a diagnostic laparoscopy. So it's way down the list of investigations for fertility. But in that case, it wouldn't be just a diagnostic laparoscopy. It would be a laparoscopy to see if the endo is there and treat it if we find it. But in women who've been appropriately treated with surgery, I don't usually rush into IVF right away after surgery unless they're older and they have a low egg count. I give them a chance at natural pregnancy, especially the first 6 months, which is when studies have shown that pregnancy chances are the highest. And if they're not pregnant after 6 months, then we will reevaluate and see what else we're missing and then consider IVF.
I think, Sadika, your point is very, very, very well taken. The only thing, like you mentioned, but in passing, that the devil is in the detail. Age is extremely important, so you can't just group everybody under the same umbrella. Older patients have less time, and they may not have the luxury of saying, "Oh, just go and live your life." I think that's one aspect that we have to mention very clearly. And the other one uh, is there value on knowing what the ovarian reserve is, in general? I think there is. I don't know how you feel about it, but I do feel that there is value there in knowing where people are starting. Although, studies have shown that the impact of that is not that much around below the age of 34, let's say. But nevertheless, if they're older, they probably should know where they're starting because that may have an impact. I don't know how you feel about it.
No, absolutely. I actually get an AMH, an ovarian test, on all my endometriosis patients because I've picked up so many patients who have low ovarian reserve unexpectedly. They're young. And I started my case scenario by saying patients who are young and healthy and have no desire for pregnancy. But I've had so many patients have to go through egg freezing either before or after surgery because we incidentally find that their egg count is extremely low and not appropriate for their age. And I have a theory. I think it's the endometriosis itself. So the way it develops in utero, when the endometriosis grows, for some reason, those ovaries don't develop as well as they should, because those are not necessarily patients who have endometriomas on their ovaries. They have endometriosis elsewhere, but their ovaries look normal on ultrasound, but they just have so much less eggs than they're supposed to for their age. So I completely agree with Andrea. At age and AMH are two important variables. But I've meant for patients who are young, have no desire for pregnancy, and they have a good AMH, there's no need to scare them because I have a lot of patients who come see me and say that my GYN told me I can't get pregnant because I have endo. That is not true. Not everybody with endometriosis will have issues getting pregnant. And if we treat the endometriosis surgically, then we're starting fresh. And then we can, like Andrea said, reevaluate who needs a push towards IVF sooner rather than later, and who needs to have their eggs banked because they may not have the luxury of time.
And also, we'd like to mention, also to reassure people that, and actually, Horace Roman, you mentioned Horace's paper earlier, showed that in patients around 32, let's say 32, 33 years old, regardless of what their MH was, greater or lower than 2, the chance of pregnancy at 36 months was exactly the same, natural pregnancy. So, this excessive anxiety especially on the part of REIs, that somebody shows up with an AMH completely normal, 1.7, 1.5 or something like that, and they'll be like, "Oh my God, it's so low." Tons of data shows that really makes no difference, in the medium term. In the long term, I don't really know, but certainly we don't know, and maybe there's an effect. But
And age is the
those
most
patients do the
important
same.
determinant.
They do the
Correct.
same.
I published on this. Age is the most important determinant of pregnancy,
Always is.
regardless of AMH level. I agree with you.
Yeah, so it's a clear factor that REIs are not even aware of it, and it's very annoying, when they don't know these things. So this idea, oh, don't have surgery because you have an AMH that's lower than 2, it makes no difference really. Like the decisions is multifactorial probably.
Also, hiding in the back there, who joined us, is Ram Cabrera. Hi, Ram. We're
Hi
gonna
guys,
move
how
on.
are you?
We're gonna talk about IBS in a minute, but I wondered if you could answer a question about fertility, because you do plenty of that too. Do you recommend excision or ablation around an ovary? And look,
Well,
we people ask the question, I have to ask it to you. So
first of all, I would like to congratulate Doctor. Oh my God, your presentation was amazing. We were trying to do. I was the director of reproductive medicine here in Mexico last year. I stayed for 2 years as as the director, and we try to change a lot of things around reproductive medicine here in Mexico, because many doctors in IVF, they only see the endometrioma and don't look forward to see deep endometriosis in the bowel, bladder, or even the diaphragm. And now, as Professor Vidalis told us, Dr. Ashraman even show, yeah, now in their last publication, that if we remove the full endometriosis, that means total excision, we enhance the possibility not only of pregnancy, only to take a home baby, because some of the reproductive clinics, they only see if you get a beta positive, and that's like, oh, I get you pregnant. But it's not a take-a-home baby. Sometimes these type of pregnancies, as you already told us, we have found out here in Mexico as well, that we perform a proper excision done by a really good expert, a team of multidisciplinary teams of experts. The percentage of pregnancy goes even higher, and sometimes just by natural pregnancies. But I would like to also add that we have to individualize each case. To all our patients now in Mexico, we're trying to provide to all of them something is called endomapping, that in Latin America is something really common. And also, we also provide to all of them, even if you don't have endometrioma, anti-Mullerian hormone, and also an ovarian count of follicles. With this, we individualize each case, and the good clinics, they attack sometimes first. If you have a low ovarian reserve, sometimes we perform a cryopreservation before surgery. And each case should be individualized. But the most important part, to answer the question of Sally, is I think that proper excision even make better quality of eggs, even if you have low quantity, of you have a low ovarian reserve.
Although we have to mention, sorry, like, we have to add one tiny little thing, which is that, and it's not that tiny, that a lot of the studies now from Europe, Roman, Mario Malzoni, people, and Marcello Ceccaroni, people who are really the leaders in this area, real leaders, they are doing a lot of ablation at the base of the endometrioma utilizing argon laser, argon beam coagulation.
Argon.
And this is an acceptable technology. And although it is a form of ablation, it's accepted. It may not be optimal, and that was the Francisco Carmona paper, by the way, because that's what they meant about that. And in the US, we've been very slow to accept this technology, because it's like, if anyone mentions any form of ablation, it's like anathema. But let's accept that, these people are doing really high-end work in enormous numbers. So we have to accept that it's something we have to think about, for endometriomas in patients with fertility, something to be considered.
I have a question.
Yes.
So, Sidika, you showed in your presentation sort of subtle endometriosis on the bottom of the ovary. I have a question. It's for the panel. How does the mapping, the pelvic mapping, play a role in that subtle endometriosis that you were showing?
So I do my own pelvic ultrasounds for my patients. Oftentimes they come and say, well, doctor, I just had an ultrasound and it was normal. And I tell them, I understand that the anatomy, the organs themselves may look normal to a radiologist. Yes, you have an ovary here and ovary there, but it's the relationship of the organs to each other that also matters. And so I often will look for the deep pelvic endometriosis on my ultrasounds. I'll look for the orientation of the uterus, the relationship of the ovary to the uterus, if there's adhesions or not. But sometimes even I cannot see those superficial peritoneal implants because they are just not visible on ultrasound. So what I tell patients is I don't see signs of advanced endometriosis. I don't see deep infiltrating endometriosis of your bowel or your uterosacral ligaments, but it doesn't mean you don't have endometriosis. I suspect if we were to do surgery based on the symptoms and everything you're going through, we will probably find stage 1 endometriosis. And I can't say that every single time I've been right. I have to be honest. Most of the time I've been right. There are cases where I go in and I'm like, how did I miss this endometriotic plaque? It's not, the big nodules we can see, but there are certain size implants, plaques that sometimes I miss. And then I go back and look at my ultrasound to see why I missed it, what it looked like. And that helps us even as physicians self-educate and learn more, because this is not something someone taught us in school. No one taught us how to do pelvic ultrasounds. All the surgeons that do their own ultrasounds, most of us had to take our own learning module. So most of us had to read our own studies, watch our own videos, and learn by experience on how to detect those things. But that's speaking of myself. Maybe Andrea or Ram have a different response, but I can say that the small superficial, that stuff that I showed you on the ovary, that I was not picking up on ultrasound because it's so small.
Well,
Ram, do you have anything to
oh,
add?
no, sorry.
Yes, well, that's really important. I think that that's the most important part, that we have to remember that we have even published in the imaging studies that superficial endometriosis peritoneal, in most of the cases, we can just suspect it. In the endomapping, it's impossible to see something that is just superficial. So endomapping is just being done by like Luciana Chamier and other really experts in radiology to see deep endometriosis. So now, before going to surgery, it's mandatory for us to see an endomapping for deep endo in the bowel, in the bladder, or other organs. But if you still go to an expert in radiology and they came back negative, that means that the expert radiology mapping was negative. That doesn't mean that you don't have endometriosis. That means that you probably have peritoneal disease. And it's also causing fertility pain and other issues. So I think that's something that should be really, really, really enhanced, and also to be really precise for patients.
Excellent. So before we switch over to IBS mode, we're gonna talk just a little bit about adenomyosis. I want to remind people that we're going to have a full hour presentation on adenomyosis on February 24th with Rachel Haverland. But tell me a little bit, Sadiqa, how do we know how much the adenomyosis will affect fertility and especially implantation?
That's an excellent question. I get asked that question every day because we are finally doing our endo excision. We've removed all our endo, but we suspect adenomyosis, and patients just want to get pregnant as soon as possible. However, unfortunately, the adenomyosis in itself can decrease pregnancy chances, regardless of what the status of the endometriosis outside the uterus is. So even with a complete excision, because those patients have really precious embryos, I want to give every single embryo the chance at pregnancy. So usually I would recommend treatment of the adenomyosis. I know I mentioned that briefly without discussing what the treatment was. The complete resolution of adenomyosis would involve a hysterectomy. That's the only way to say we got rid of the adenomyosis, is if we remove the uterus, have the pathologist look under the microscope and confirm the presence or absence of those endometrial glands and stroma within the muscle layer of the uterus. So as a physician, as a surgeon, I can say I suspect adenomyosis based on either the look of the uterus surgically being globularly inflamed and enlarged, or looking at the ultrasound findings of the uterus looking a little swollen with ultrasound findings suggestive of adeno, or even a hysteroscopy that may show signs of adeno. So I can say I suspect it, but I cannot completely confirm it without a hysterectomy. But when I do suspect the adenomyosis, especially in patients who have heavy bleeding, who have irregular spotting, all of those are signs of adenomyosis, then I would recommend treating it with Lupron. Lupron is an injection that puts women in menopause. It cuts down the estrogen supply to the uterus. And in this way, we are giving a break to those endometriosis deposits that live within the muscle layer of the uterus so that they can shrink, so that it can decrease that inflammation that's present in the uterus itself. I do Lupron for about 2 to 3 months prior to transfer with AdBac. AdBac is a pill they take to help counteract the negative side effects of the adenomyosis, of the Lupron, the hormone shutdown. And then we do an embryo transfer. That's how I typically recommend. Sometimes we add letrozole. Letrozole is another medication that can help shut down the estrogen production within the uterus. But I cannot say what impact the adenomyosis has on the pregnancy, because we either treat it or we don't treat it. And if we don't treat it and they don't get pregnant, we don't know if it's the adenomyosis or something else. But if I treat it and they don't get pregnant, then we can say, look, we did everything we can for the adenomyosis. You did not get pregnant, but let's think of what else we can do. What else could it be? But if I don't treat the adenomyosis with the protocol that I recommend, and they don't get pregnant, then we don't know if it was the adenomyosis or something else. I would be interested to hear if Andrea or Ram have anything to add on that, because it is a very big controversial topic. We're having this discussion with surgeons, which is excellent. I get attacked when I have this discussion with fertility doctors because their perception may be very different and their recommendations may be different.
Yes.
Andrea, as the reproductive immunologist in the room, how is your approach maybe a little bit different?
No, I agree with Sadika. I pretty much agree with everything you said, Sadika. My only question is that we don't really know how Lupron actually, we don't even really know if Lupron really increases implantation rates or certainly pregnancy rates. We don't know that at all. The whole endometrial factor is completely ignored. It could be that it's just causing some sort of a hard reset on the lining. A lot of these people have messed up linings, they have inflammatory changes in the lining. So maybe it's not that you're doing anything for the adeno, you're just sort of like resurfacing the endometrium and that's all you're doing. And maybe why do 3 months of it? You know, you could probably achieve that in 3 weeks. That's my question. You know, I'm not really that convinced about that.
Let me tell you one thing, Andrea. I'm sure maybe you've come across this study. There's actually a paper that was published by my school when I was a fellowship, the McGill University, that talks about exactly what Andrea just said. So they looked at patients that had Lupron and letrozole before an embryo transfer, regardless of the reason for fertility, and compared it to patients who didn't. And interestingly, those that received Lupron and letrozole had higher pregnancy chances. And so you're
Oh,
right.
no, there's papers on that, but very small studies, unfortunately. You know what I'm saying? And the reason why letrozole is because, you know, it shuts down the peripheral aromatizations because you
Testosterone to
have to
estrogen.
remember, like, you know, you got estrogen floating around that comes from somewhere else. But maybe it's the letrozole alone. You see, because letrozole increases levels of integrins. So like you don't really know. We don't really know. That's the answer. Yeah.
Is there an age cutoff for when you would do this treatment, or this conversation I've definitely had with Andrea before, but do you think about the patient's age when you're thinking about this type of treatment? Andrea, you first and then Sadika.
You have to, mostly because when you have a patient that doesn't have a lot of embryos and they're older, and you have to consider that by the time you do a luprosuppression, set them up for a transfer, blah, 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 retrieval, you're talking 6 months. So these people would do 2 retrievals in a year. And maybe they're 39 years old. So like, you know, time has to be considered as a very important factor. So there's a lot more nuance about this whole process than what we're talking about here. We're sort of like sculpting just the outline of a statue. There's a lot of nuances in this. And hopefully at the summit,
Right.
where
Now,
everybody
in
will
all
attend,
fairness, we sculpt the outline because we dive deep. Actually, Sadika and Andrea are going to do, we have 2 separate panels that they're both going to do so we can dive deep.
that's we
So
hope to dive deep there. So come to the summit, everybody.
I mean, I'm amazed at what's going to go on at the summit. So, there are questions in the chat. I'm going to answer those when we log off of Facebook. So don't worry, everybody will get their questions answered. But we have to switch gears. It's a 2-night panel. It's a 2-topic panel night. I want to also invite Dr. Sadika to join us somehow on Instagram, because this is wild how many people have questions and we can't wait to do more with you. But Ram, you are up for IBS. Is it IBS or is it endometriosis?
Yes, I'm ready. And thank you so much, guys. And I'm so happy to. Oh, are you seeing my screen right? Or you're seeing like share screen? Yes, I don't know.
We are seeing you and
Normal
the
or like
presentation mode.
navigator?
We're seeing the speaker mode or whatever.
Oh, that's strange. I don't know why. Let me just change this. Oh, like that. Yes, perfect. Now you can see it, right?
We gotcha.
Oh, perfect. So thank you very much, Andrea, Sally, and oh my God, it was a great presentation about fertility. I think I even took some screenshots because I have even a lot of work here in Mexico. I used to be the director of reproductive medicine here, and it was out of this world. Still some issues that we have to take care here in Mexico, because as in the US, many reproductive just doctors, they don't understand fully endometriosis. So I really want to congratulate this topic. And now my topic, that is one of the most important parts, and many of the patients are misdiagnosed or subdiagnosed with just IBS. And that's why we have to talk about this. It's not always IBS. So I'm Dr. Ramiro Cabrera. I used to be the director of reproductive medicine here in Mexico. Now, thanks to God, is Dr. Armando Menocal, who is also a great friend of ours. I'm one of the head directors in the LATAM, and also head surgeon in the Global Group and the Yen Institute. So first of all, I want for you guys to remind, I even gave this topic in the AGL. That's why Sally, I think, invited me, because it was a really interesting topic, because we want to change things around the world. As Dr. Vidali and all the doctors, we have been traveling the world and see how patients suffer differently in Latin America, in the US, Canada, even in India, how they are struggling with the disease. Many of these patients are misdiagnosed with other diseases like IBS. They think that they are with psychiatric disorders, or the pain is in their mind, or they sometimes don't believe in the patient, because pain is not an objective sign. You cannot see pain. You cannot measure pain like you measure the temperature. So you have to be really careful with this. And because many doctors cannot diagnose endometriosis, sometimes these patients are misdiagnosed with other diseases. So this is something that we have to change. We have to remind that 1 in each 10 women around the world have endometriosis. That's over 200 million women affected worldwide. And let's just remind that this incidence was 20 years ago, before endomapping, before even the new technologies. Now we have even robotic surgery with even 8K resolution, 4K resolution. So we can diagnose even more endometriosis. So probably the incidence 1 each 10, maybe even subdiagnosed. So we really have to be careful about this, because it's a disease with a really high incidence. We have to also remind that this disease is not cancer. My dad used to be the president of oncology here in the country, and cancer kills people. But the problem about endometriosis is that it cannot kill you, but it totally affects the quality of life and also the fertility in women. So we have to change that as well. This is one of the most important slides that you will see in your whole life. That something is happening worldwide, no matter the country. Many patients have symptomatology even from the teenage years, as soon as they start the first menses. They start going in first world countries to a general practitioner or general gynecologist, and by shame, even though they are a really good doctor, they are not expert in endometriosis. Or in first world countries, we already know, it's already been published, that it takes up to 10 years to get diagnosed. And that doesn't mean to get good treatment. There's a minimum rate around 5 to 8 specialists to get diagnosed for endometriosis. And some of these doctors even make surgery, or they may misdiagnose patients with irritable bowel syndrome, interstitial cystitis, or other pain symptoms or pain syndromes that by shame is the incidence of endometriosis even higher. By shame, these poor patients can go under even 12 surgeries. I have a patient that have gone under 12 surgeries, and that doesn't mean that they treated correctly. They do ablation. Sometimes they start just doing just chemical castration without even noticing the disease. So we have to be really careful, because the disease will advance, and if the disease continues to advance, it can cause two main complications. That is infertility by obvious reasons, by the change of anatomy, and also chronic pelvic pain, and sometimes even central sensibilization and peripheral sensibilization that can cause pain that has to be treated by a group of physiotherapy with that expertise, as well as neuropelviologists. So you have to be really careful about this. When I was studying endometriosis in Brazil, I also went to Europe. I start to see the disease a little bit in an advanced way. So we even made a self-diagnosed application by symptomatology. And when we start seeing how much the US cost was per year, It was really strange for us, but we found out that just by direct and indirect costs, the US per year take up to $78 billion in the cost of endometriosis just in one country. This is because many patients goes to the ER or goes to IVFs, goes to many surgeries, and this is really bad because even it's a healthcare issue right now worldwide. As you can see, a patient that has chronic pelvic pain cannot work properly. So there's even a low productivity, and that makes indirect cost of the disease. And the delayed diagnosis, when you go to the ER and they order a tomography, and remember that tomography doesn't help us to diagnose endometriosis, that's a totally loss of money. So if the US understand this, that they are losing so much money, they will start making more investment in correct diagnosis and treatment. The first thing that we have to remember that Professor Ray told us is the good definition about endometriosis. We have to remember that endometriosis is not a disease just of the reproductive organs. It's a chronic inflammatory multisystemic disease in which endometrial-like cells are born and grow outside the normal endometrial cavity. And what it causes is it causes chronic inflammation and multi-organic dysfunction, depending in the organ affected. So the old definition that was just glandular and stroma outside the human uterus, that's really old. It's a chronic multi-inflammatory disease of the full body. And right now, it's really important for us to understand that endometriosis has different levels. The first thing that we have to understand, there are different types of endometriosis, from peritoneal disease that cannot be diagnosed by endomapping. We can suspect it by clinical symptoms and some indirect signs during ultrasound or MRIs. The one that we must diagnose before any treatment, medical or even surgical, it's deep endometriosis. Right now, worldwide, in countries like Brazil, Italy, in New York, like with Dr. Vidali, and even in Mexico, we can perform something it's endomapping. And with correct endomapping done by true experts in radiology, we can see deep endometriosis and what organ is affected before going into any surgery. And the obvious ovarian endometrioma, that is the most important part. We even make something that it's a mnemotechnic to remember the clinical symptoms. So the first symptoms, as we already know, is the legendary dysmenorrhea, that it's pain during menses. That remember, no pain, it's normal. The normal things do not have pain. So dyschezia, dysuria, and everything else is depending in the organ affected. And the most important part is that if you feel that your clinical symptoms is not normal during menses, please, you have to go to a really good expert. This is really important because I have seen all over Latin America. I have gone and traveled around the countries doing surgeries around Bolivia, Guatemala, and other countries. And many of these countries, they just stay with the clinical suspicion. They send it to a radiologist that is not an expert. The radiologist came back that the uterus and the ovaries doesn't have anything, and then they stop thinking about endometriosis. So they believe that the patient have something wrong in the psychology aspect. But now we know that patients that do have endometriosis and they have endometriosis close to the bowel or even in the bowel may mimic symptoms like irritable bowel syndrome. That's why my father and grandfather are really good doctors. They used to believe that patients that have a chronic inflammation in the bowel, that they have pain bowel movements, that they have chronic constipation, diarrhea that was obviously enhanced during menses, they used to believe that it was just IBS because in that moment there was no endomapping. The only way to diagnose endometriosis at that moment was just by laparoscopy. And that was really wrong because if you enter to a just laparoscopy without a good mapping, then you cannot diagnose endometriosis before going into surgery. Sometimes there's no bowel surgeon during that surgery, and you will stay forever with that symptoms. And as you can see in this slide, endometriosis in the bowel can mimic symptoms like irritable bowel syndrome. But let's us remind that the incidence of endometriosis is 1 in each 10. It doesn't mean that 1 in each 10 women have endometriosis in the bowel. It means that if you have endometriosis, you may mimic symptoms, or you may even have both We have also seen that the irritable bowel syndrome is more common in patients that have a multisystemic inflammatory disease. So this is really important. Why? Because before going into any type of diagnosis or treatment, we have to individualize each case with the greatest possibility of detection. The most advanced diagnosis is better for you the outcome. So now, before going into any type of diagnosis or any type of treatment, surgical or medical, we should provide the patient something is called endomapping. It should be done either by MRI or ultrasound. We know now that it's not a normal ultrasound or a normal MRI. This is made in world centers like Dr. Mario Malzoni here, with Professor Ash Roman, with Professor Chacaroni, with Dr. Vidali. And this type of ultrasound is not just a transvaginal ultrasound. We have to see the diaphragm, the bowel, the appendix. Even during transvaginal ultrasound, by obvious reason, we see the uterus and the ovary. But as you can see, we also see the bladder, the bowel, and even the ureters. And it's really amazing when you see someone do a correct mapping. And sometimes many patients come with already an MRI. By obvious reasons, I will not talk about tomography because tomography has no really good outcomes or diagnosis endometriosis. So an MRI is not a normal MRI. This is mandatory for you to understand. If they're going to do an MRI on you, that you should ask for a rectal and vaginal gel if it's possible, and also medication for the intestine not to move. And as you can see, the MRI has lowest sensibility and specificity because the ultrasound can be moved and you can see the lesions, how they can even be attached or detached to other organs. I hope that you understand this well. Thanks to God, Dr. Luciana Chamier is something that we should talk here. Luciana Chamier is one of the main radiologists worldwide that is publishing about this, and she make it something possible. In 2024, she made the first consensus in the radiology to understand that a normal ultrasound cannot diagnose endometriosis, and you have to put it in levels. So now, thanks to Dr. Chamier and all the group of radiologists in the US, now you have and you can ask for the different levels until you can get into a mapping. So the mapping is really important. Why? When we enter to a diagnosis laparoscopy, no one in the world, and this is something that my father used to say, I have to get into surgery to see if you have endometriosis. But there's a big problem. The human eye cannot see through tissue. So even if we enter to a diagnosis laparoscopy, there's no one in the world that can see the nodule in the bowel, the length of the nodule, where is it, if it's affecting from the anal verge. And this is really important because sometimes when we have to treat the bowel, it's important to let us know the amount of endometriosis that you have in the bowel or other organs so we can treat it. So remember that what can see through tissue is an ultrasound and MRI. In my center in Tijuana, in Mexico City, we provide both because it's a private practice, and the most information that we have about your endometriosis, then we can treat it even better. So I know that many of you in the US and Canada still use, and even our friends from Brazil, there's Dr. Mauricio Brau made a really good application for the staging system for deep endometriosis that can be even done by ultrasound, a really good app. But we also provide something that is called the NCIAN classification. This is something that we use in many centers worldwide that can be shown before surgery. This is mandatory if you are suspecting endometriosis, and even if you have an endometrioma. Now in many centers, if you have an endometrioma or we are suspecting endometriosis, we provide an endomapping, and this endomapping we provide before surgery this classification. And with this, we can see if you have endometriosis in the bowel, and it's really important to see if you have endometriosis nodule. If it's really small, even the treatment is different. If you have a really small endometriosis nodule, then we can shave it off, and it's super easy with low risk of complications. If you have an endometriosis nodule of 8 centimeters, then we cannot shave it off. We have to do a bowel resection. And it's also really important for you to even decide if you want to go under bowel surgery, because also bowel surgeries have higher risk complications. Also, a bowel surgeon should be in the room, and also you have to decide what you're going to do with your body, because some of these cases As we already know, we have stopped doing something that is called ileostomies or colostomies for this type of cases. So this is really important because many patients, as you are seeing here in Spanish, obviously, but we provide to all patients before surgery an NCCN classification, and with this, we approach before surgery in a multidisciplinary team of fashion with the colorectal surgeon that will see you before surgery, so you can talk, and then we can decide and individualize each treatment. This is important. Something that is really important is that many patients worldwide are diagnosed with endometrioma. That means a chocolate cyst. Now we know that up to 85% of patients that have endometrioma also have endometriosis in other areas, either the bowel, the bladder, or deep endometriosis in the uterosacral ligaments or around ligaments. So this is important because we can see the nodules by ultrasound, and we can see it in an MRI, and this is mandatory to do before surgery. And with this, remember, it's not always IBS. If you have endometriosis nodule that it's affecting the layers of the bowel, by obvious reasons, you will have bowel inflammation, you will have diarrhea or constipation if it's affecting the hypogastric nerves, and you even may have a pain during defecation or even rectal bleeding, depending in the affected area in the bowel. Also, as you can see here, we can decide with you what we want to do or during surgery. If you have a bowel nodule of 10 centimeters that is affecting the full circumference of the bowel, then we cannot provide the patient just a shaving. By obvious reason, the disease will stay. If we have a really small nodule, we can tell the patient that we will just shave. So this is mandatory to know before surgery. This is something that has been published even by many professors like Dr. Horaz from Mario Malsoni, Chacaroni, and even now in Mexico, we even have even evolved the technique so we can provide this type of treatments. I published this technique that is something that we created here in our institute to optimize the time and even the form of surgery. In some cases that you have adenomyosis and you have endometriosis also in the bowel, then we can diagnose before surgery, as you're seeing here. And then before surgery, and I will just put a little bit of this because I know that many patients are seeing, and sometimes this is really, really just for doctors. But if you have a big bowel nodule, we can even do an en-bloc technique. That means that we can take away the uterus even with the bowel, and at the same time to take it off, we put together back the bowel to do a full bowel resection. So patients that gone under surgery, you can see right there the nodules inside. If you want to see the full video, I can send it to you, but this is for doctors. But this type of nodules, as you're seeing here, I'm sorry about the explicit content, but it's really important for you to see how endometriosis lesions can affect the full layers of the bowel. And this type of techniques that we develop enhance the time and lower the complication rates. That means low risk of comorbidity. Now we can provide a full bowel resection in less than an hour and a half. Before we used to do a full bowel resection with an hysterectomy in 4 hours, 3 hours. That means less risk of anesthesia procedure, risk complications. So this is really, really important because this make really, really enhancement in postoperative complications. Something that's really common in Mexico is that many patients still believe that they go to a general colorectal surgeon or a gastroenterologist, and they suspect endometriosis in the bowel, and they do a colonoscopy. By shame, colonoscopy should be only performed in patients that have rectal bleeding or a history of cancer in the colorectal area. Now we know that by the nodule is extrinsic to the bowel, so it grows from outside to inside. So please, if someone ever make you a colonoscopy and they tell you you don't have endometriosis in the bowel, tell them that you have less than 5% of chances to see the nodule in the mucosa area. So colonoscopy should be only done in patients that we already know that have endometriosis in the bowel, but you have rectal bleeding or history of cancer, but it do not diagnose deep endometriosis in the bowel. And also, this type of surgery should be done by true experts like Professor Vidali, Malsoni, Chacaroni. because in our centers that are in high volume, we perform more than 5 to 10 surgeries of the bowel each week, not each year or each month. That means that we have a little bit more experience, and by obvious reasons, our rates of complications are less. This is really important because if you do not provide this type of treatment, sometimes any colorectal surgeon can do a bowel resection, but not all of them can do it with neuropreservation. So this, if you do this type of surgery, should be done by true experts in deep endometriosis in the bowel. If not, sometimes patients go under surgery and they defunctionalize the bowel, and they can even end up with bowels after symptomatology. So this is really important because we know that a true expert doing surgery in bowel can have an improvement in bowel symptoms and even fertility rate. So this is really important. After taking away the nodule, then it's really important to see that many patients stop having IBS. But by obvious reasons, we have to individualize each case. And by the end of it, also to enhance the reproductive outcomes, if you have a colorectal nodule that's so big that makes inflammation, makes like this ambient that is against pregnancy, many of us have published that if we take away the disease, that means a total excision, the fertility rate, by obvious reasons, make it a progression and also enhance. So please, we're trying to avoid ablation anymore. Ablation doesn't have even recurrence. The disease stays all the time. It recurrence when you have a comeback of the disease. Recurrence happens when you have excision and then the disease come back in another organ. When you do ablation, you don't have recurrence. You have this is what is staying. So this is really important because ablation almost all the time will have a recurrence. And this is important as well, as Professor Vidali told us. Ablation should be done only in really, really few cases. I will suggest to never do ablation. Just maybe you have a low ovarian reserve, and then we can do ablation with in the ovary with the argon laser, or we can even use better the alcohol. But if not, we can provide full excision, and with this, the disease will have low recurrence rate. This is really important. So thank you very much. I think that's the end of my presentation. I think I can help you a little bit with this. But let's also remind us that life begins with pain ends. So this is really important for many patients to understand what's high quality diagnosis for deep endometriosis. So thank you very much, Sally, for the opportunity, and I open to questions.
Wonderful, wonderful, wonderful. Thank you. We are running a little over, so I appreciate your time. I'm going to ask a few questions, and then I have a question for Siddiqa as well. So first, Ram, how do you tell the difference whether you have to shave or whether you have to go all the way through the bowel? And what is the chance for recurrence with shaving?
That's really important. As you saw, before going to surgery, we provide a high quality mapping, and the radiologists tell us that the size of the nodule and also the distance from the anal verge and the percentage of the circumference affecting the bowel. If you have a nodule that is less than 1 centimeter, that is not affecting more than 30%, 20% of the bowel, we can shave it. And with this, we have a little bit less recurrence. But if you have a nodule of 10 centimeters and you want to shave a 10 centimeter nodule, you will always have recurrence, because it's even really, really dangerous for us to do, because also remember that endometriosis causes fibrosis. In that case, it's better to cut off. If you have a C3 nodule, that means that a nodule is affected more than 3 centimeters in the area, more than 50% of the bowel circumference. It's better to cut off that part of the bowel and then put back together two healthy tissues. I don't know if I'm making myself clear.
No, you are making yourself clear. And we were actually asked to we have a webinar with Dr. Gabby Mawad where we show it visually, but somebody asked us to update it. So I'm so excited that you brought this topic up, so we're able to put that in a compilation up on our YouTube. Siddiqa, I have a question. I get this all the time. Patient calls, they do a consult, they have unexplained infertility. And maybe like the third or fourth question that I ask are, does your stomach hurt? And they say, well, if I eat a lot of fiber, if I drink enough water, how often do you find that somebody has sublimated their IBS-like symptoms and it's really endometriosis?
All the time, all the time. I actually just saw a patient today before I came over to do this webinar. She says, well, my bowels hurt when I'm on my period, but if I go on a gluten-free diet and I'm strict with what I eat, then I feel okay. But that's not okay for someone to have cyclical bowel pain. That is a very strong indicator of endometriosis. And I tell my patients, you may have both, you may have endo and IBS, but unless we do the surgery to look for and remove the endo, we cannot say this is not endo. And I would say about 99% of the time we're right and there is endo. It doesn't necessarily have to be on the bowel itself. It could be around the peritoneal organs, but because the bowel rubs on those inflammatory implants, they have bowel symptoms. But if they have unexplained infertility and they are telling me they have some bowel symptoms, we cannot see it's IBS, because IBS is a diagnosis of exclusion. It's only after you've excluded everything can you say it's IBS. And if we don't look for and diagnose endo, then we may be wrong.
Yeah, my other favorite one, topic of a different webinar, is I drink too much water. That's why I have bladder
I have to go pee all the
frequency.
time.
No.
Right. But
100%.
if
No.
it's coming with some miscarriage and some other symptoms, then we don't.
Yes.
Yeah. Now, Ram, do you find that you see the bowel symptoms more, or IBS-like symptoms, in teenagers a lot that's misdiagnosed?
Yes, by shame, many patients that come to our clinic was already with many bowel symptomatology. But as I told in the AGL, right now, to the difference between IBS and bowel endo can be really easy to understand just by listening to the patient. If you ask the patient if the bowel symptoms enhance during menses, then it's more probably that you have bowel endometriosis or endometriosis that is affecting the parametrium or really close to the hypogastric nerve. And then many patients that have endometriosis, even superficial endometriosis that affect the hypogastric nerve, can cause bowel symptoms. So now we know that many teenage patients may have peritoneal disease that may be affecting the uterosacral ligaments, and with this, just by continuity, it's affecting the nerve that they innervates the bowel, and with this, they have bowel symptomatology. By obvious reasons, many gastroenterologists, as Dr. Or Professor Sharika says right now, it's really hard for them to understand the disease. So they will always think it's IBS. They will give IBS medications. With that, they may make a little progression, but they will still have a lot of symptomatology. And you can see how many patients, just by nutrition therapy with a good anti-inflammatory diet, they make a really good regression of symptoms. But if you have a nodule that have a 10-centimeter nodule, like really big, like the one that I do almost every day, that cannot be treated just with medication or with a normal diet. If you have an obliterated nodule that almost causes occlusion, then sometimes surgery is necessary.
Yeah, I think Sadiqa hit the nail
Yeah.
on the head when she said, by the way, IBS is a diagnosis of exclusion, and
Yes.
endometriosis needs to be excluded before people just say it's IBS. Okay, we are way over. So sorry about that. The Endometriosis Summit 2025 is happening March 28th through the 30th in Orlando, Florida, and virtually. Tonight's webinar is a very good example of two topics we will dive deep in. Dr. Siddiqa, we are going to have you on two panels, one of which is one of the few times at the Endometriosis Summit where we allow for patients to ask questions about themselves in our fertility panel instead of just theory. Usually we only allow theory questions, but it's going to be your first Endo Summit. What are you looking forward to the most?
I'm really excited to be part of this amazing group because I really support patient advocacy. So I'm very excited to be directly able to communicate with patients rather than just educate other physicians and colleagues. Because, I go to a bunch of conferences every year and we do that. But I really want to help undo those really bad beliefs that or this miscommunication or misinformation that's out there that patients have gained through either their physicians, their GYNs, or some internet searches. And so I really want to help set the record straight on endometriosis and fertility and be there as an advocate for patients who can help give them accurate information on what they should do to help increase their chances of pregnancy. So that's what I'm excited for the most, is just communicating and directly getting in touch with patients that need the expertise.
I am so happy to have you because, by the way, I was connected to you through Nancy Peterson, and she said to me I wasn't really having an endometriosis summit with fertility advocacy unless I had you. And so then I knew you were fabulous, and you are amazing so far.
Thank you.
Amazing.
I appreciate you. Thank you so much. I'm happy to help.
So, Ram, your first time in person with the Endometriosis Summit, and you also will join Endo Summit Spanish. But what are you excited about the Endometriosis Summit to see?
Well, oh my God, I'm really excited because, as I told you before, we create something. It's called Dolatam. That's this non-profit organization, so we can help patients all over Latin America. Thanks to God, you're in the US and Mexico. It's also a country that's in being of development about deep endometriosis. Now we can provide full treatment. But imagine patients in Guatemala, Dominican Republic, or Bolivia that I just went. And some of those patients, like I just did, a patient with diaphragmatic and even a pulmonary disease. Imagine the quality of life of that woman. So I think that the most important part of making an endo summit in Spanish is that it will go even further, as well as many patients in the US will understand better how advocacy can help to change lives. And the most important part, as doyen, the meaning of doyen in French is the most educated woman, or most this woman that used to be the reference in France. So I think that, as I tell to all my patients, the more knowledge that you have in your disease, the more power you have over it. So I think that the most high quality education, like we just say with professor about fertility and also in bowel, they will understand better the disease, and this will make them get better type of outcomes and also type of surgery, diagnosis, and whatsoever. So I'm really happy to help with this also in Spanish, because my main language. So thank you very much for having me tonight. It was a pleasure. And oh my God, Dr. Sadika, we will talk later because we have to change a lot here in Mexico in reproductive medicine. So you will be invited in a lot of congresses here in reproductive medicine. Thank
I
you.
wish I spoke Spanish, but I don't. But I speak English, French, and Arabic. So if you have any French-speaking patients, happy to help.
I have a program that'll AI everything into Spanish for you. So don't you worry. We can hook you up with that.
Perfect.
Endo Summit Spanish is offered for free to the Latin American community. So I just want to remind people about that. But if you're looking to learn more about endometriosis, you can register for the Endometriosis Summit, www.theendometriosis.summit. And while I'll stay behind to answer some questions on Zoom, I want to say good night to everybody. Take care. We are back next week with coping with the holidays. Take care.
Thank you.
See you soon, guys. Bye-bye. Happy holidays.
Happy holidays.
Bye-bye.